So we are now discussing the local anesthetic agents. We discussed the general anesthetic agents that numb the entire body and cause someone to be unconscious. Now, these local anesthetics they do cause a reversible loss of sensation in a localized part of the body, okay, when applied direct on a nerve tissue or mucous membrane. So they are actually local according to the name. Basically, where they are going to be administered, that's where they are going to be working. So these ones will suppress action potential in excitable tissue by blocking voltage gated sodium channels. Remember, we said that for the general anesthetics, they've got a lot of mechanisms of action, including working on potassium channels, including working on the GABA receptors, potentiating them, and also working on glycine receptors. But for the local anesthetics, is sodium channels. That's important to understand. So in so doing, they're going to be able to inhibit action potentials in these pain receptors and then block the transmission of pain. Now, the way we classify local anesthetics is you classify them number one based on the chemistry. So you have got esters and amides. Okay, the esters includes cocaine, procaine, tetracaine, benzocaine. You can see basically this guy is cocaine, procaine, tetracaine, benzocaine. How can we even remember that? Well, you have got A, B, C, and then PT. Okay, just remember those four. The amides, you have got lignocaine, which is also known as lidocaine. You have got bupivacaine, levobuvacaine, mepivacaine, prilocaine, etidocaine, ropivacaine. So basically, if you can understand the esters, that will be better. But again, when you look at the amides, they have got a va, like vacaine. You can see for the esters, you cocaine, procaine, tetracaine, benzocaine. But these ones, most of them, they have got a va, buvacaine, levobuvacaine, mepivacaine, prelocaine. But some of them, they don't have the va there, okay? But you can know them like that. You can also classify these local anesthetics depending on the duration of action. Some of them work for longer, others for shorter. And then also, there are some of the local anesthetics that are used in ophthalmology, like when you are dealing with eyes, and that's the proparacaine. Okay? And then you can also classify the local anesthetics according to clinical use. So there are some of the local anesthetics that are used in surface anesthesia, just the surface, like tetracaine, lignocaine, cocaine, benzocaine. Okay, just the surface. And then you have got infiltrating anesthesia and field block anesthesia. Like these are going to be able to go a bit in lidocaine, procaine, bupivacaine. And then those are to be able to block the nerve. So nerve block, anesthesia, procaine, lignocaine, bupivacaine, tetracaine, ropivacaine. So you can see that lignocaine is actually falling on all of these. Spinal anesthesia, lignocaine again, tetracaine, bupivacaine. And then epidural anesthesia, you have got the lignocaine, bupivacaine. So basically different ways in which you can classify this. So the most common local anesthetics in clinical use today are the clinical local anesthetics, which you can classify as amino esters and then amino amides. So I've got the esters and the amides. Okay. Now these two classes differ not only in their structure but also their metabolism and allergic reactions. Right. And so also that differs. And then you have got the synthetic local anesthetics, the cocaine derivatives. They come from cocaine. And these ones differ from cocaine because they are of a much lower abuse potential. Cocaine is much abused, and then they do not cause hypertension, vasoconstriction. Okay, of course, with a few side effects. And the synthetic local anesthetics end in cane. So the local anesthetics, according to duration of action, you have got the short acting, medium, and high duration of action. So the short acting, have got benzocaine, procaine, chloroprocaine. The medium lidocaine, which is the common one that you'll be able to see, also you've been doing is even in skills lab, okay, even lumbar puncture, and prelocaine. Not procaine, but prelocaine. The high duration, you have got tetracaine, bupivacaine, cincocaine, ropivacaine. Even the names sound even heavy. They have got a high duration and they have got high potency. Okay, the medium duration they also have got medium potency. So therefore, local anesthetics, you can also classify them into the injectable ones, the surface anesthetics. The injectable, you have got the low potency, which is procaine, chloroprocaine. The intermediate potency, you have got lidocaine or lignocaine and prelocaine. High potency tetracaine, bupivacaine, ropivacaine, dibucaine. The surface anesthetics, you have got the soluble and insoluble. Like these ones are for the surface, you don't inject them. Okay, for the surface, the soluble ones, you have got cocaine. It can dissolve in water, lidocaine. You have got tetracaine and then proparacaine. So you can see that lidocaine is both an injectable and a surface. The insoluble ones, you have got benzocaine, butylamino benzoate, and oxyethazane. Not that something you should really master, but at least know some of the basics. Now, how do these anesthetics really work? So you need to understand how pain happens. So pain is transmitted. You have got different types of fibers: the A fibers, the B fibers, the C fibers. The A fibers, specifically A delta, transmits pain. Okay, A delta fibers transmit nociception and cold. That's why when there's a competition between temperature and pain, because you can see they're transmitted by the same nerve. The C fibers also transmit pain, but these ones transmit pain that is dull in nature from skin and viscera. Like you can't really tell where the pain is. The A delta transmits fast, sharp pain. So that's important for us to know. So therefore, what will happen is that when you stimulate the pain receptors, there's going to be depolarization, which in turn activates the voltage gated sodium channels. And once these have been activated, there's now going to be so the voltage gated sodium channel is a complex structure and it has got a pore forming subunit associated with one or two beta subunits. So the alpha subunit is made up of domains. Like you have got the domains from 1 up to 4. And then you have got the beta subunits, they can be 1 or 2. So meaning the alpha subunits comprises 4 domains, and each one of the 4 domains contains 6 segments, S1 up to S6. And these wrap around the bell-shaped central channel. So the channel is formed by the S5 and S6 segments and short loops of amino acids. Now the inactivation gate is formed by a loop connecting domains 3 and 4. Don't worry much about this, but S4 in the domain has a positively charged arginine or lysine amino acid, and is the voltage sensitive region of the sodium channel, so the S4. But don't worry about this. This is much detail, and don't worry much about that. Okay, so this is just what I was trying to say. You can see I've got different subunits. You have got the parts 1, 2, 3, 4, and each one of them have got 6 different parts, S1 up to S6. Okay, and this S4 that is going to contain that sodium channel. So really what will happen is that when there is resting, the sodium channel is closed. But when there's a change in action potential, you can see the inside of the cell is becoming more positive. There is depolarization happening. Then there is activation of this sodium channel, which will cause their opening now. And then you get to take sodium much in. And once that happens, you can now inactivate the gate. So the mechanism of action of local anesthetics: these drugs are water soluble, they dissolve in water. Okay, they are water soluble. And the structure of local anesthetic consists of 3 parts: the lipophilic aromatic group, an intermediary link, and hydrophilic amine. As you can see, the two types that we mentioned, the esters and the amides, look at this. The lipophilic part is the same, the intermediate group is different, the hydrophilic part is the same. Okay, it's only the intermediate group that's different. So the intermediary link will be the one that will determine whether dealing with an ester or an amine. You can see the amino group and then the ester group there. Local anesthetics provide a differential block in concentration dependent manner. So this is what happens. So a lipophilic anionized local anesthetic molecule crosses the phospholipid neuronal membrane like a lipophilic anionized. If something is anionized, it means that it is lipid in nature, so it can cross the lipid membrane. And once that happens, the molecule will be able to dissociate to reach a new equilibrium of ionized and ionized moieties. So basically, at the end of it, what we are basically saying is that you have got this molecule that is anionized to be able to enter the cell, attached to the receptors. Once you attach to the receptors, then you get to increase, you get to cause an action potential. Okay, that is going to make more sodium to enter the cell. Now, the pharmacological properties of the local anesthetics. When you look at the local anesthetics, local anesthetics with a low pH, pKa, have a fast onset of action, and those with a high pKa have a low onset of action. Now, pKa corresponds to is indirectly proportional to pH. If pH is high, actually to Ka, not really to pH. So if Ka is high, pKa is going to be low. Okay, so I don't want you to worry much about this, but just here take note. Local anesthetics with low pKa have a fast onset of action. Inflamed and infected tissue are more acidic in nature, and therefore more local anesthetic exist in the anionized form. When you have got acid, okay, like for tissue that is inflamed, you have got more acid there. This acid will be breaking this local anesthetic to become ionized, and that will reduce the amount of the unionized drug. And so, since you don't have much of an ionized drug, this cannot cross the nerve because it's the unionized drug that crosses the nerve to provide the analgesia. Okay, so this at this point, the drug might not really work. Okay, so the pH of the tissue can be affected by different other things like adjuvants, other things that you can add together with the drug, like bicarbonate, to be able to speed the onset of epidural anesthesia if you add bicarbonate. And why is that? Why is it speeding up the reaction? Because if there is bicarbonate, it means that the drug is going to be in the unionized form and then to be able to cross barriers and be able to act. Local anesthetics have got a high protein binding. They bind to alpha 1 glycoprotein. They have, and have a longer duration of action if they bind to binding proteins like alpha 1 glycoprotein. The reason for that is if something bind, it means that it's going to have more time to spend in the body. Okay, hypoxia, if there's a drop in oxygen concentration, hypercapnia, like you have got too much carbon dioxide and acidemia, these will decrease protein binding, and so they increase the risk of toxicity because the drug is not bound, so it is more going to work. And then when you look at the absorption of these drugs, the order of peak plasma concentration or after a single dose is intrapleural. So this is just showing you which ones, how these drugs will be able to work when you get to inject them. You have interpleural, intercostal, lumbar. So like the intrapleural, if you inject the local anesthetic in the pleural region, interpleural space, or intra, it works much faster than the lumbar epidural, and the lumbar will work much faster than brachial plexus. Okay, so in other words, the area where you inject the drug is important for its action. It's not like you should master that, all right? And then the metabolism and clearance, esters and amide local anesthetic agents differ. So esters are broken down in plasma by pseudocholine estrase. to the metabolite para-amino-benzoic acid, which we call PABA. And this byproduct PABA causes allergic reactions. So those local anesthetics which are esters in nature, they cause the allergic reactions. Now the amide local anesthetics, these ones they really don't cause these allergic reactions. Okay, so it's important to understand that. So basically that is the principles of the local anesthetics. Again, these are questions now that we can try to answer. Which as the fastest onset? Okay, now this is a combination of both local anesthetics and general anesthetics. Which anesthetic is the most potent? Which inhalation? Okay, that's general. When this one is on general anesthetics. Which of these local anesthetic is most likely to cause allergic reaction? So what the question is just asking is that which one amongst this is an ester? Because you should be able to identify which one is an ester, and then that will cause a allergic reaction. The technique of local anesthetic will include all the following except, or in what way can you inject the local anesthetics? Which one of these? Epidural, neuro, leptanalgesia, intravenous regional anesthesia, infiltration. So how do you give the local anesthetics? The rate of systemic absorption of local anesthetic is affected by all of the following except pharmacological property, constitution of the solution, vascularity. So please try to answer this question. We are going to be able to discuss them, but try to answer them. We see how we are going to be able to work with them. Name a local anesthetic agent that causes vasoconstriction. Okay. All of the following are inhalation. Okay, that's on general. So these are some of the questions that you can attempt, and then we'll be able to discuss in the next class the answers.